Assalamu alaikum. Let's talk about heavy metal toxicity. What are the heavy metal toxicity we will discuss? We will discuss about these four heavy metal toxicity: L, I, A, M. That is Liam. Liam Livingstone, one of the English batter, who is an all-rounder, plays very well. Okay, L for lead, I for iron, A for arsenic, and M for mercury. So these four are heavy metal, and we would like to discuss about the heavy metal toxicity of these four. Start with lead poisoning. Lead risk factor is home built before 1917. Home built before 1917. Very high yield. Pica, one of the eating disorder or mouthing behaviors, infants, developmental delay, siblings with lead poisoning and low socioeconomic status, an immigrant or international adoptee may be asymptomatic. There may be abdominal pain, constipation, cognitive impairment, or behavioral problems. There may be encephalopathy. We know lead actually interferes with enzyme involved in heme synthesis. So lead actually interferes with the enzyme involved in heme synthesis, leading to microcytic anemia. It leads to microcytic anemia. It also disrupts the calcium homeostasis and subsequently impairs calcium mediated release of neurotransmitter and interrupting appropriate neurologic function. In lead poisoning, the managed and lead can be encountered in where we found the lead in battery manufacturing, in automotive repair shop, or environmental exposure like water contaminated by lead pipes and lead contaminated soil. And childs are usually susceptible to lead exposure through the lead based paint. Okay, uh, in lead, it can result in basophilic stippling of red blood cell. There may be basophilic stippling on red blood cell we will find in lead poisoning. It if we go through the lead if we go through the heme synthesis pathway, if we go through the heme synthesis pathway, lead actually interferes the heme synthesis. Okay, and chronic exposure of lead comes with the lead lines in the bone at the metaphysis, and at the junction of the teeth and the gingiva there may be bruton line. So lead line in the bones and bruton line in the teeth can be found in chronic exposure of the lead. Management: obtain venous sample if screening performed by capillary sample If screening performed by capillary sample, obtain venous sample, notify public health department, nutritional counseling, and chelation. If lead level is more than 45 microgram per day, no metabolic acidosis or no hematesis versus iron poisoning. So in here, there is no metabolic acidosis and no hematosis. But in iron poisoning, there may be metabolic acidosis. In iron poisoning, there may be high anion gap metabolic acidosis. Okay. Approach to childhood lead poisoning. Does the child have the following risk factor? Home built before 1978, under renovation, or with peeling paint, pica, sibling with a lead poison, low socioeconomic status, Medicaid, and immigrant or international adoptee. No, no further testing is needed. Yes, draw the venous blood if artery, if capillary blood, if sample is taken initially from the capillary blood. Now draw the venous blood. If it is undetectable, no further testing. If it is mild, 5 to 44 mcg per dl, no medication. Repeat in less than 1 month. So, and if it is moderate, from 45 to 69, meso to 3 dimercaptosuccinic acid, DMSA, dimercaptosuccinic acid, dimercaptosuccinic acid can be seen, can be given. And if it is more than 70, dimercaprol plus calcium disodium EDTA, calcium disodium EDTA should be given. So what is the next step in the management for a child that have elevated lead level on capillary blood? Measure the venous level. Capillary blood testing is a good initial screening, but false positive results are very, very common. So that's all about lead toxicity. Now the iron. Now iron toxicity or iron poisoning. Clinical features within 30 minutes to 4 days. It is in iron toxicity. It happens through direct corrosive injury to the GIT or through inhibition of oxidative phosphorylation. It results in profound metabolic acidosis and cell death. We know that iron toxicity can cause high anion gap metabolic acidosis. It is for acute, and there is chronic iron toxicity. We know that in chronic iron toxicity or overload occurs from chronic transfusion, or it happens chronic transfusion, or it can be happen due to hereditary like FHFE gene mutation like hereditary uh, hemochromatosis, which is autosomal recessive HFE gene mutation leading to excessive iron deposition in the various tissues. In iron poisoning in acute, within 30 minutes to 4 days, there may be abdominal pain, vomiting, diarrhea, hypotensive shock, and metabolic acidosis. There may be hagma, that means high anion gap metabolic acidosis. Within 2 days, it is hepatocyte necrosis, 2 to 8 weeks, pyloric stenosis. So within 2 days, hepatic necrosis, within 2 to 8 weeks, pyloric stenosis. In here, there is anion gap metabolic acidosis or high anion gap metabolic acidosis, and radio diagnosis is radio opaque pill, radio opaque pill, and treatment is whole bowel irrigation. Treatment is whole bowel irrigation. and the chelating agent, iron chelating agent like deferoxamine, deferasidox, deferipron. These are the drugs for iron chelating agent. And supportive care for A, B, CRA, breathing and circulation. Supporting is CRA, breathing and circulation. And we know that iron uh, can accumulate in the different parts of the body in chronic cases if there is hereditary hemochromatosis. If hereditary hemochromatosis like HFE gene problem, HFE gene problem in skin, there may be hyper pigmentation in musculoskeletal, there may be arthritis, particularly in the second and third MCP joints, there may be chondrocalcinosis in GIT, there may be elevated liver enzyme, hepatomegaly, cirrhosis, hepatocellular carcinoma on endocrine. There may be diabetes mellitus, hypopituitarism, hypogonadism, hypothyroidism, and in cardiac there may be restricted and dilated cardiomyopathy and conduction abnormalities. There may be conduction abnormality. Okay, and there may be conduction abnormalities. So that is all about iron toxicity. Now, next topic is arsenic. Arsenic is the third heavy metal which causes toxicity. Arsenic, if we go through the mechanism, arsenic actually disrupts what it disrupts cellular respiration. It disrupts cellular respiration. How? By inhibiting pyruvate dehydrogenase. It inhibits pyruvate dehydrogenase. It inhibits pyruvate dehydrogenase, a key enzyme in TCA cycle, causing uncoupling of oxidative phosphorylation. So it disrupts cellular respiration by inhibiting pyruvate dehydrogenase enzyme. Okay, source is pesticide and insecticides, contaminated water, often from well and pressure treated wood. So arsenic exposure usually occurs low level through contaminated water like well water and food, and exposure that increase the risk of systemic toxicity like exposure to mining, pesticide and pressure treated wood. So pesticide, insecticide, pressure treated wood, this would be the chronic or long time exposure, and contaminated well, uh, and daily intake of contaminated well water may cause arsenic poisoning. So it binds, in mechanism, it binds to sulfhydryl group, disrupts cellular respiration and gluconeogenesis. It disrupts cellular respiration by inhibiting pyruvate dehydrogenase. In acute uh, manifestation of arsenic, there is garlic breath, vomiting, watery diarrhea, QT prolongation, garlic breath, watery diarrhea, vomiting, and QT prolongation. QT prolongation also seen and can develop dysarrhythmia like Torsades D pointis. And garlic breath and profound hemolysis are seen with arsine gas exposure. And on GIT, it can cause hematemesis. It can cause hematemesis and sometimes it results in hypotension and pulmonary edema. Okay, in subacute or chronic exposure, there may be hypopigmentation or hyperpigmentation, hyperkeratosis, stocking globe neuropathy. There may be stocking globe neuropathy, and there presence of Mees line. There are lots of lines I have talking about, like lead line, presence in lead poisoning, Bruton's line on the teeth, presence in lead poisoning, and Mees line, horizontal striation on the horizontal striation of the fingernails, and development of multiple types of cancer. Development of multiple types of cancer. Okay, arsenic poisoning. Arsenic poisoning diagnosis by urine arsenic level are preferred test in the setting of suspected toxicity 24-hour urine level. So diagnosis is urine arsenic level. Diagnosis is urine arsenic level, and CBC can be done to see pancytopenia and bone marrow suppression. Liver function test can be done, show unconjugated hyperbilirubinemia in arsine gas exposure, and ECG QT prolongation, sometimes torsades D point is may be seen. And in acute arsenic poisoning, treated with chelation using dimercaprol or succimer, dimercaprol or succimer, and chelation therapy is not effective for patients with arsine gas exposure. And arsine gas exposure, it, uh, it is not that effective. So diagnosis is confirmed with elevated urine arsenic level. Antique furniture builder presents with pol antique furniture builder presents with polyneuropathy, areas of hypo or hyperpigmentation on the neck, tingling in the hands, looks like arsenic poisoning. Mees-line horizontal striation of the fingernail are characteristic. Horizontal striation of the fingernails are characteristic. And we know arsenic induces DNA damage, disrupts cellular mechanism promoting carcinogens, such as in the skin, lung, liver, and bladder. Finally, the Liam Livingstone, the final one is mercury poisoning. So last poisoning is mercury poisoning. It is not that common, but we need to know about this too because it is one of the heavy metals. So mercury, it's an element and organic bound element, and organic forms are highly lipid soluble, are easily cross blood brain barrier. So mercury toxicity actually causing brain problem because it cross the blood brain barrier and leading to neurotoxicity. It can cause it can't cross the alveolar membrane and thus forms chemical pneumonitis due to inhalation. And inorganic mercury salts are highly corrosive when ingested, causes profound injury and the GIT. So one thing about mercury, what we need to remember in this heavy metal toxicity, mercury causes neurotoxicity. So one line, mercury toxicity can cause neurotoxicity, and in mercury toxicity it can be occupational like mining, light bulb manufacturing, recycling, dental amalgam, mercury amalgam, environmental, living near the industrial mining site, and dietary, large consumption of large predatory fish, and exposure to cosmetic or herbal remedies that contain mercury, product skin lightening product. And mercury toxicity. The clinical feature is neuropsychiatric. There may be tremor, insomnia, personality changes, cardiovascular. There may be hypertension, tachycardia, mucocutaneous. There may be gingivitis, diaphoresis, swelling, redness, discommotions of the hands and the feet. In on renal, there may be renal tubular damage or proteinuria. There may be renal tubular damage and proteinuria. And how can you diagnose mercury? 24-hour urine mercury testing, blood mercury testing, and serum and urine catecholamines. Serum and urine catecholamines are elevated in chronic mercury toxicity. In chronic mercury toxicity. And in mercury, there is chelation via chelation with succimer DMSA or chelation with succimer DMSA or dimercaprol, and chelating therapy is ineffective for organic mercury toxicity. So that is all about the heavy metal toxicity. The livingstone, the lithium, sorry, lead, iron, arsenic, and mercury. It's a very high yield topic. Hope you enjoy.